Okay, folks, so we're on Chapter 22, Part B of the respiratory system, and this really follows Part A. And in Part A, we really start talking about the anatomy for the most part of the respiratory system. And in Part B, we're really talking about the physiology, right? And so when we discuss physiology, we're looking at really how the respiration works, how this process of taking in, oxygen and taking out carbon dioxide really function in the lungs, in the respiratory system. Okay, so we're looking at the mechanics of breathing and how this actually works on the overall picture. So we're looking at how the lung tissue opens up and closes during breathing, and it actually so we see two phases. We actually see two phases in pulmonary ventilation: inspiration and expiration, right? So inspiration is, breathing in, and expiration is breathing out. And again, we're talking about gases coming in and gases coming out. So when we're breathing out, again, carbon dioxide, breathing in oxygen. And so when we look at actually inspiration and expiration, we know that pressure is involved in the mechanics of actually opening up our lungs, inspiring and expiring, breathing out our lungs. So we know that pressure exists, and pressure actually works on gas, right? We've got water pressure, vapor pressure, but then we also have what we call gas pressure, right? And in fact, things like oxygen, carbon dioxide, other gases that exist in the environment are in fact gases, right? So they're considered gases, right? And these gases all are, influenced by pressure, right? So pressure, we know that pressure works on the outside of the body and on the inside of the body. So we know that pressure exerts its forces in the inside of the lungs and the outside of the lungs. And we know for the most part, if we're at sea level, for most of where we live, we have a certain pressure, and that pressure is equal to 760 millimeters of mercury, and that's what that stands for, or 1 atmosphere. And again, generally speaking, this is an average for most towns, cities, unless you, again, specifically go to a city like Denver, Colorado, which is a mile-high city, which is actually a mile from sea level. And of course, the pressure will change there. But for the most part, if we're looking at sea level pressures, it's at 1 atmosphere, or 760 millimeters of mercury, right? So when we talk about pressures as they relate to the respiratory system, we compare them to atmospheric pressure, right? So this is, 1 atmosphere is actually the pressure, ATM, and that's really, we relate it to that, right? Any pressure that we're talking about is in relation to if we're increased or decreased the atmospheric pressure, right? And so when we talk about negative pressure, that's less than atmospheric pressure. And if we're talking about positive pressure, that's greater than atmospheric pressure, right? So again, greater than or less than right? And when we talk about zero pressure, that means we're equal to the pressure of the atmosphere. Okay? Greater than, less than, or less than, greater than, and equal to. And again, we are describing it in relative to atmospheric pressure. So we've got a couple different pressures that exert their forces on the respiratory system. The first one we're talking about here is intrapulmonary pressure. Okay, intrapulmonary pressure. And this is the pressure in the alveoli sacs, right? This would be an alveolus, and that would be the pressure inside the alveoli, right? Intra-alveolar pressure, okay? This pressure is going to fluctuate. It's going to decrease and increase, again, based on if we are inspiring or expiring, right? Again, that's based on if we're breathing air in or breathing air out. And again, as we breathe in and out, it's always going to eventually equalize with atmospheric pressure. So we'll get to a point where this, when we expire, will equal the pressure outside the atmosphere, which again in sea level it's 1 atm, right? See this this example again in a second. Intrapulmonary pressure is actually the pressure in the pleural cavity. So again, this is between the pleural cavity, right? This would be lungs, right? This would be the thoracic cavity, right? And this area here would be described as the pleural cavity, which we discussed briefly in part A, right? This would be fluid filled, in fact. So we know this one's going to fluctuate with breathing. As we open up the lungs or inspire, we're going to decrease the space there and increase the pressure. When the lungs expire, when we blow out air, we're going to increase the space and decrease the pressure there as well. So we know that the interpleural pressure is always negative. Okay, it's always less than the atmospheric pressure, and on the average it's 4 millimeters of mercury less than pulmonary pressure, in fact. Okay, and pulmonary pressure, or the pressure in the alveoli, all right, so always 4 less in the intrapleural pressure, or in the pleural cavity. Okay, so fluid levels always have to be kept at a minimum. So there's always a threshold there of fluid that needs to be kept, because again, if there's extra pressure, that would be extra pressure, right? Extra pressure, extra fluid is going to equal extra pressure in the pleural cavity. Okay, and who's responsible for the fluid balance there? The lymphatic system. So there is actually lymphatic capillaries there that are in charge of pulling out that fluid. Okay, if the fluid becomes positive, right, positive pressure, not negative pressure, then pressure develops so much that the lung can collapse. So when we're talking about interpleural pressure here and lung collapse, okay, what we're describing is the process that is involved in expiration, right? And that's the process of the lung as we are blowing out carbon dioxide, okay, decreasing, right? And because of that, the alveoli, for example, would actually decrease, and all the alveoli would decrease and blow the air out, right? So we have two forces, basically two conditions here that actually help promote lung collapse, right? which is actually a good thing. This is what we need to expire, right? Number one, the lungs' ability to recoil, right? Recoil, because the alveoli have elastic fibers located pretty much around the alveoli. These elastic fibers act like rubber bands are surrounding the alveoli and tend to push down or collapse or promote the collapse of the alveoli, each individual alveoli, naturally, right? And of course, you have the surface tension of the alveolar fluid, right? So these are, in fact, type 2 cells. If you remember this from part A of the chapter, or earlier in the chapter, and they secrete that surfactant that then leads to the helps with surface tension. Right, so this the surface tension actually helps pull the alveoli to decrease it in size. So they actually promote this as well. So the elastic fibers surrounding the alveoli and the type 2 cells secreting the surfactant that adds to surface tension actually promotes the collapse or the alveoli getting smaller. So this is actually how we blow out carbon dioxide, which is easy to do. It's harder to inspire, take in air, than it is to blow out carbon dioxide. So what happens when we inspire? What helps to kind of ease that and make it not such a difficult task, right? Outward forces that we take in actually help push open the lungs, right? One being the elasticity of the chest wall. Okay, this actually helps push the thorax downward. So what we mean by that is, if you remember your skeletal muscular system in AMP1, you know that there is a lot of cartilage in the ribs, right? The structure of the ribs themselves, and the fact that they're not completely encircled, they're attached with cartilage and not completely a complete cage, if you will. And then all of your muscle that lines in between the ribs themselves and surrounding outside the ribs, that all makes everything elastic. And the diaphragm, right? This all leads to elasticity. Okay? So the last pressure we're going to see here, type of pressure, is what we call transpulmonary pressure. And transpulmonary pressure is actually the two pressures that we discussed. The difference between those is called transpulmonary pressure, right? Difference between those two is transpulmonary pressure. This difference in pressure actually keeps the lungs open, okay, and keeps the lungs from collapsing completely. Because as we expire, the lungs will reduce in size greatly, but they won't completely collapse. There will always be a little bit of air left over, and there will always be some sort of pressure, and that's what we call the transpulmonary pressure. Okay? The greater the transpulmonary pressure, the larger the lungs will be. And if they, for example, those two pressures equalize, or the alveolar pressure equals to the pressure outside the lung, we will have lung collapse. And this is actually collapsing, where the lung deflates basically completely and cannot inflate, right? And so this is what we're seeing here, right? We're seeing the intrapulmonary pressure, interpleural pressure. We know that the interpleural pressure is always negative, and it's on the average negative 4 atm, right? Versus the atmospheric pressure, right? So it's always negative 4, right? That's why you can see a negative 4 there, or negative, or 756, because that's 4 less than atmospheric pressure, which is 760. So if you notice, that's 756, 56, which is 4 less than atmospheric pressure. Okay? And so transpulmonary pressure, the difference there is, in this example, 4. Right? 4. In that range, again, we can inflate and deflate the lungs, and there should be no issue whatsoever. So what happens in a pneumothorax, right? Pneumothorax can actually cause a collapse, right? This a pneumothorax is actually air, atmospheric air in the pleural cavity, and then we see lung collapse from that. Okay, so they give you an example here. Let's say a knife wound could introduce air, right? Air into that area there, right? And that air actually equalizes, right? So as the atmospheric air, let's say it's 1 here, eventually inside the interpleural cavity it would be 1 atm, and that would promote lung collapse. And you can actually see lung collapse here. That's the lung tissue there, collapsed completely. And so what you normally have to do is repair this area here, repair this area, or block those areas to, and then increase the pressure to allow that to inflate. And that's what you see there. Okay. All right. So ventilation, pulmonary ventilation is inspiration, expiration. Again, breathing in and then breathing out, right, is what we call pulmonary ventilation. Okay. Again, it works on volume changes, right? Air volume changes, right? Those volume changes will always lead to pressure changes, right? So again, this has to do with physics, right? The less room that the gas has to move around, the more pressure, the more times that the molecules will run into each other, and then that force applied, that energy that we see, is pressure, right? So this is how we describe it in physics, right? It's the relationship between pressure and the volume of gas. We call this Boyle's law, right? So pressure is inverse with volume, right? If you have volume on one side and pressure on the other, anytime you decrease the volume, in Boyle's law says you increase the pressure. That's an inverse relationship. When one goes down, the other one goes up, right? Okay, if you decrease pressure, it's always coupled with volume increasing, normally speaking, when we talk about air, if you will, right? Inverse relationship, right? Goes down, the other one goes up. Okay, so what's involved in inspiration? We have muscles involved in that, and these are the muscles of the thorax, and in particular the diaphragm and what we call the external intercostal muscles. Those are the ones that lie right outside the rib cage. Okay? Not in between the ribs, but outside the rib cage. We call these external, not internal, external. Okay, so the diaphragm is a dome-shaped muscle. So when it contracts, it actually flattens out. So much like the diaphragm, my example here, if that is a relaxed diaphragm, then a contracted diaphragm would look like this. And we'll see a picture of that in just a second. Okay, so that by contracting increases the volume of the lung. Okay, and so when the external intercostals contract, the rib cage gets lifted up and out, and that also results in the increase in thoracic volume. So again, both the diaphragm and the external intercostal muscles are both at play when this, and you can see this for a fact, right? If you look at the diaphragm, okay, diaphragm there, okay, we see that in contraction there, and then we see it in relaxation, right? When we inspire, we actually bring in more air, so the diaphragm moves down this way, and when it relaxes, it makes that dome shape structure like this versus like this. And when the intercostal muscles contract, they cause the ribs to open out and this to open up. And the opposite is true with the ribs when we expire or blow out, right? So it's evident here where you can see the arrows going this way and the force going this way, right? Again, if you wanted to draw this to draw around a circle, kind of following the line of this, obviously by outlining the circle, you can actually see that this one is bigger size than the top one is a bigger size than the bottom one. Okay, so as the volume increases, the lungs get stretched out because they're pulled by the thoracic cage. Intrapulmonary pressure drops by 1 millimeter mercury, 1 atm. Air flows into the lungs until pulmonary pressure equals to atmospheric pressure, right? So what happens when we do deep breathing, deep inspiration? Again, this can happen in a vigorous exercise, COPD, which is an issue with the respiratory system, but this really deep breathing. Other muscles are also involved, the scalene muscles, sternocleidomastoid, pectoralis minor muscle, which is your chest muscle, the rectal spinae muscles, all actually work in deep breathing as well, right? Part of the figure, right? So let's talk about expiration. Quiet expiration is normally a passive process, so as you breathe in, normally speaking, and breathe out, it's a passive process. As those muscles relax, right? We're talking about the diaphragm and the external intercostals relax. The volume decreases. The lungs, because of their elastic fibers and that surface tension also help to decrease the volume and blow out air, right? Forced expiration is what we call an active process, and we actually use the oblique muscles and the transverse abdominal muscles. Those are your abs. Both of those are ab muscles. And the internal intercostal muscles, those are the muscles in between the ribs. Can also be used in forced expiration, right? And so again, we see this here, right? Figure 22.16. All right. So this figure 22.17, we're looking at how pressures, intrapulmonary pressure, transpulmonary pressure, and interpleural pressure change. And we couple that, or we add it with another graph that looks at the volume, right? So at what point in each of these graphs do you see volume changing, right? So when intrapulmonary pressure goes down and interpleural pressure goes down, volume starts going up, and the opposite is also true when transpulmonary pressure goes up and interpleural pressure goes up, volume's going to go down, right? So you see that on the left of the graph and the right of the graph. Okay. So we also have air moving through the lungs, and we actually don't use really the respiratory system when these things occur per se. And again, they can modify respiratory rhythm, the normal breathing rhythm that you might have. These are usually because of a reflex, right? But some are voluntary. Or for example, when you cough, when you sneeze, when you're crying, laughing, hiccuping, yawning, those all are what we call non-respiratory air movements, because we actually use air in and out when we do all of these things, right? Okay, so let's talk about these physical factors that actually let air pass through the respiratory system. One being the airway resistance, that surface tension that we've been discussing, or that I mentioned here earlier, and what we call compliance, okay? So here's airway resistance, right? Okay. So we couple it with not only the flow of air and the pressure of air, but resistance, right? Okay. And so resistance is anything that stops air from flowing or slows it down, right? And the biggest one is friction, right? And that's where air molecules, for example, will brush by, run into an object, another molecule, cell, or tissue, and it causes this, friction, this slowing down, if you will, this rubbing against, if you will, called friction. And that's usually the biggest factor, the biggest type of resistance that we see. Okay, so we see resistance, for example, again, our respiratory tree is our friend. It's beneficial, but it's also can be a means of resistance, right? When we look at the diameter of the airway, right, in the conducting zone, it's usually quite big, right? And as we already have figured out, right, those airways, those branches get smaller and smaller, and that actually leads to an increase in the cross-sectional area. And resistance are usually going to be in those medium-sized bronchi, right? The medium-sized bronchi, usually your secondary, tertiary, right? The respiratory bronchi. But once we, as we get smaller, right, the hole gets smaller, you're going to have increased then resistance, right? That would be our little small bronchi there. We would increase resistance. And once we get to the terminal bronchiole, okay, in the terminal bronchiole, this is where, again, gas exchange is really important, right? That's where that function occurs, right? And diffusion plays a role in actually moving the gas past that point, right? So again, if we look at the terminal bronchiole, this is where we see pretty much the dividing line between the conducting zone and the respiratory zone. And again, we see resistance normally at the high point being the medium-sized bronchi. And as we get through past that point, resistance really goes way down, right? And it's usually not that important after a certain part, and then after the terminal bronchioles, resistance is not really a factor. So when we talk about resistance, when we talk about how air is not getting through into the lungs, one of the major factors is resistance. And so we have to go back and look at that part of the bronchial tree to see if possibly that might be the issue with somebody that, can't breathe in oxygen too well. So again, as resistance rises, as we get an increase in resistance, breathing movements become harder to do, more strenuous, right? So we get this really from some disorders, right? From constriction, or when we block the bronchioles, right? So those can be impeding breathing. That can be life-threatening, right? For example, asthma can do that. Bronchitis can do that. Pneumonia infection can do that. Mucus buildup can do that. So we've got a lot of different ways that actually this can happen, right? And a chemical we call epinephrine, that's actually a synthetic hormone, right? Or it's actually a real hormone, but synthetically we use it to apply it to the patient, right? They will dilate the bronchiole, right? So if this was my little bronchiole, epinephrine applied, much bigger, right? You increase the volume of the bronchiole, you're going to decrease resistance, right? More space for air to go through, resistance goes down. Okay, so in surface tension, right? Those liquid molecules tend to draw each other together because they have the surfactant, right? And they reduce contact with other gas molecules like air. And that actually is a good thing, right? Decreases resistance. And again, the surfactant is that surface tension type of fluid. And again, it's produced by the type 2 alveolar cells that are part of the alveoli. All right, so we see this sometimes in premature infants where they don't produce enough of this surfactant. Those type 2 cells are not producing enough surfactant, and which can lead to what we call infant distress syndrome. The surface tension is obviously increased because there's less surfactant being secreted. Leads to more of a collapse in the alveoli. And then the alveoli must be completely reinflated during each inspiration, and that uses a ton of energy to do that. Right, and again, preemies, we usually see this issue, right? Because premature they've missed several months, or sorry, several weeks for a lot of cases in the mother's womb, and they miss development time. And because they miss development time, one of the issues is development of the type 2 alveolar cells. So a lot of the time spent towards the end of the term of pregnancy is to actually develop and strengthen lung tissue. And because premature babies miss those couple weeks, they miss the development of the lung tissue. Okay, so there's a fix to it, right? You know, medical science is wonderful, right? We have surfactants that we can actually put into the baby's air passage that acts as the surfactant they would normally produce, right? Positive pressure equipment can also keep them open, and again, this can actually resolve the issue until they develop their lungs to capacity. Lung compliance, right, is the measure of the change in lung volume, which is coupled with the change in pulmonary pressure, right? It measures how much of a stretch the lung has, right? Okay. And this can actually you can look at how healthy the lungs might be, right? In fact, right? Higher lung compliance means it's easier to expand, right? And again, we can look at this, right? Compliance, the changes in volumes between each pressures. And again, we can look at this all day, but I don't need to study that there. But all that's saying is, again, volume and pressures are also related to compliance, which is C, right? And again, compliance is the measurement of volume of air that goes in and out of the lung tissue, right? Okay. So again, that can be compromised by many different things, right? Surfactant, not producing enough surfactant, the flexibility of the thoracic cage. Maybe there's a skeletal system issue, disease. Maybe that might be a muscular disease. Maybe it might be a tissue disease. And all of those can lead to actually less compliance or less healthy. So again, there's many different reasons why, right? Again, inflammation is one big one. Tuberculosis causes a massive inflammation, and then scar tissue replaces normal lung tissue. We call this fibrosis, and that can actually lead to a decrease in lung compliance. Production of surfactant is also an issue as well, as we just mentioned. And again, lower the lung compliance, more energy is needed to use those muscles. Okay. So again, deformities, right? Skeletal problems. Not only the thorax, costal cartilage, muscle issues can all lead to as well. Okay, so we actually use different volumes to really paint the whole picture of lung compliance as well, right? And so we're able to calculate those. We're called respiratory capacities, and which leads us to the compliance values that you've seen in lab. And again, this is part of this this experiment this week was to actually calculate those compliance values, right? Okay, so let's define these, because we took a look at them, we ran them on the machine, lung compliance barometer, and so now we need to define what those mean, right? So tidal volume, or TV, is the amount of air moved in and out of the lung with each breath, right? And that's about 500 milliliters, okay? 500 milliliters. So The IRV, right? The inspiratory reserve volume is the amount of air that can be inspired forcibly beyond the tidal volume. So if you normally breathe in and then breathe out, that's your tidal volume. But if you breathe in and then continue to breathe until you can't hold any more air, that's IRV, right? Which is about 21 to 3,200 milliliters past the 500 milliliters. Expiratory reserve volume, or ERV, is the amount of air that can be forcibly pulled out of the lungs. Again, you blow out, and then you blow out as much as you possibly can, and that's about 1,000, 1,200 milliliters. And there's always a little bit of air left over, and we call that the residual volume. That's the amount of air that always remains in the lungs, and that's a value you don't need to calculate. That varies, but it's about 1.5 milliliters left over. And again, when you look at these capacities, these actually are the calculation of a lot of different things, right? Tidal volume and IRV, residual volume and ERV, TV, IRV, ERV is vital capacity. And the total lung capacity, the sum of all the lung volumes, is TLC, total lung capacity, which on the average is about 5 liters. Okay? Plus or minus, of course. Depends on gender, age, overall health, things like that will increase or decrease that. All right, so we see this here, right? Okay, we see the IRV up top. There's a TV, ERV, residual volume, and then when you add many of these together, it gets these values here, and then all those together is total lung capacity. You see this at 6 liters. All right. But notice that it's male, right, on the average. Okay, so we want to make sure that we do look at these, right, when and make sure that you do know these values here as well. Okay. All right, so let's take a look at these function tests, right? The spirometer can actually look at a couple of these, right? Obstructive pulmonary disease, something that increases the airway resistance, so resistance is increased, right? Bronchitis can do this, right? Again, it's because you have an inflammation. Okay. Restrictive diseases can actually block, right? Like tuberculosis, fibrosis, and then expansion gets compromised as well. Okay. And again, that's really looking at why these tests are important. All right.